Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Kevin Irwin and Tory Jennison on the community care team model. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Handling Center for Health Leadership and Education and CCSME. The Handling Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Handling Center has designated this activity for 1.5 AMA PRA Category 1 credits. Note that this webinar focuses on the community care team model's relation to harm reduction and not the CCT program in Maine. The opinions expressed by the speakers in this webinar series are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold all questions until that time, or you can place them in the chat feature in Zoom. And with that, I will hand it off to Kevin and Tory for our presentation. Thank you all for being here today.
Cool. Thanks, Bethany. Hi, y'all. My name's Kevin Irwin, and I'm here with my friend and colleague, Dr. Tory Jennison. We'll do just brief intros of ourselves and our backgrounds. I'll pass to you first, Tory.
Great. Thanks, Kevin. Can everyone hear me? Great. My name's Tory Jennison. I am a population health doc and a nurse. I'm currently the executive director at the New Hampshire Public Health Association. I've been facilitating community care teams in New Hampshire for about 6-7 years now. And thanks to Kevin for helping us get them started. So we've also been helping other states around the country figure out how to kind of evolve their processes to community care teams. So I'm really excited to share this work with you today and hopefully support you moving forward.
Cool. Thanks, Tory. So I may have met some of you before. I've done a couple of webinars recently through CCSME. Kevin Irwin. My background is long and covers a lot of territory. We're in Maine primarily on behalf of RHI, which is Reduce Harm Inc. It's a small group of old farts like me who've been doing harm reduction related work for about 30 years. And so my background covers housing, integrated delivery networks, research, many trainings, capacity building, started a lot of nonprofits and coalitions and stuff. So created a lot of trouble, yeah, good trouble. And among one of the programs that I was involved in for a long time now was this particular community care team model. I know there's a model of the same name with some kind of specific objectives in Maine. And I want to honor and respect that. It's the same name here, so we'll just be using CCT as a reference point. I want to acknowledge our efforts here today are supported by funding from the Maine Office of Behavioral Health. And I wanted to thank Bethany and the collaborative for making everything work, keeping me in line and doing stuff I'm supposed to do. Disclaimer, the usual that, anything that Tory and I may share is our own opinion doesn't necessarily reflect the opinion or state any policy positions of the Office of Behavioral Health or anybody else. And we're, as Bethany said, we're not receiving any other specific funding that would create a conflict of interest. In my last disclaimer would be that I have a puppy here in the room with me, so things could go sideways in a hurry for a few minutes, but he's sleeping at the moment, so hopefully we're good. Objectives. I'm also going to go off screen just to keep my bandwidth high, and we'll come back a little bit later. But our objectives, just define this particular model. We'll be looking at the similarities and differences. The first thing I always hear, of course, anywhere we've ever done this is exactly what we were just talking about, is we already have one of those or something like it. It's usually called something else, or we tried it and it didn't work, or so on and so forth. So there's plenty of multi-agency cross-sector efforts around that have existed, and some of them are very good. We're just here to share this one, which has proven quite effective. We're going to just describe the value of the model in a number of different ways. We're here especially to answer questions at the end. And I want to mention up front, and I'll remind us all at the end, that we do have a number of kind of technical assistance and support sessions scheduled over the next 6 weeks. And we're also available outside of those hours if y'all would like to put in a specific request. And these could be to start a new community care team, or adapt a similar effort that's already underway, or strengthen a similar effort that's already underway. So with that, we've got basic agenda. I'll share a little bit about the history of the model that we're sharing today. Some of the core lessons learned. We've run into all kinds of stuff over the years, as you can imagine, as many of you probably participate in similar efforts and have seen how challenging it can be, but what the rewards can be are amazing. We'll review kind of the steps if somebody's starting from scratch, what we see as our kind of the must-haves of the steps required for implementation. We have a package of resources that can be adapted and adopted anywhere. We'll show you a couple of those, but we can't, fill the screens with tons and tons of super text-heavy documents. But we can tell you what that package looks like, and then again, questions and answers. So the model. This goes back a little ways, about 15 years now. I was living in Connecticut. I was working at the time for the Corporation for Supportive Housing. This is also around the time, the Affordable Care Act was coming through. Lots and lots of interest and renewed interest and emphasis on hospital utilization, especially emergency department utilization, and the management of costs associated with Medicaid. So lots of aligned interests in better serving folks. Also, at that time, many hospitals were experiencing such high volume in repeat ED utilization that the staff, really valuable qualified staff, were just getting burned out and leaving, which is a huge cost, both in financial and human resources cost. So, so a hospital in Middletown, Connecticut, Middlesex Hospital, had started a kind of multi-agency community care team model where they came together every week and met in person for an hour. And they started, data-wise, with the enumerating who were the people who were the most frequent visitors to the emergency department. That was easy data to put together. A lot of those folks have a lot in common. It's helpful to have that data, but of course, you could ask any of the staff that worked at the emergency department, and they could tell you the top 10 right off the top of their head. But that's where they started. And touching all the services staff of the folks among agencies that they were already trying to coordinate with. Put together a release of information whereby everybody could come together and speak about any of the people who had signed that release of information, right? And it proved to be, quite an effective model. It was striking to me. I participated in support in making housing resources available. to folks who were being served. And of course, many of those folks were houseless or unstably housed. We also had some other similar efforts underway in trying to create the business case for new Medicaid reimbursement to cover stuff that people actually need, not only clinical services. And I also had the opportunity to do an evaluation of this model. Got a little bit of money from a local entity there, and I'll show you the results of that evaluation shortly. But again, the primary motivation that really drove this was great increases in preventable hospitalizations and folks coming out of the hospital without, necessarily a great plan, and folks with repeat emergency department visits. So with that, I pass to Tory to share a little bit deeper insights about that.
Sure. So the community care teams that I facilitate in New Hampshire, there are 3 of them. They are, the first one got started maybe 7 years ago, I think, Kevin. We had a Medicaid 1115 waiver for the entire state. The goal was to look at ways to transform the behavioral health services experience for people on Medicaid. Part of that work, one of those initiatives, was to do a better job of connecting the providers who were serving this population, because there was a lot of those people aren't doing their job, and that organization isn't doing their job, and no one can get in touch with anybody at that organization. So one of the things that came out of a cold snap over the winter, 14 days of below freezing temperatures, that prompted some community partner organizations to go to a city fire chief and say, we're really worried about our clients, close to 40, 50 people that are living unsheltered in the seacoast area of New Hampshire. We're worried that they won't survive this coming cold snap. Folks may know that emergency management and public health preparedness are responsible for emergency sheltering when natural disasters happen. So we kind of tweaked that process, opened a shelter space first for a few days at a municipal rec center, then moved to a National Guard armory, which I recommend you never, ever do. Part of the demobilization planning for that shelter was, what do we do with these 100 people? Not only did we serve and shelter the 40, 50 that folks knew were unsheltered and at risk, we ended up sheltering over those 14 days 101 people. So now what? Now you've got 101 people that have been identified as really vulnerable, really at risk. How do we go about triaging their needs and making sure that when this shelter space closes, all of our partner organizations aren't inundated with people who have needs because they don't have the staff or the capacity to respond? So the community care team stepped up, and it had been meeting monthly and in person at a hospital. And we started meeting weekly for a couple of months after the shelter closed, then went to bi-weekly. And then when COVID came along, we switched to virtual and to monthly. And we'll talk a little bit about why and how community care team models evolve, what they look like in the beginning, how to know when they're maturing, and how to sustain them once they hit at a really good performance level. So the biggest challenge that we face now is that we aren't getting folks who are leaving shelter so much as we are getting folks referred who are leaving the hospital. And as Kevin said, and we'll talk a little bit more about why that is, but when folks are in the hospital, they're getting care coordination because everybody that's seeing them works for the hospital system or is organized by the staff in the hospital system. Then when they're discharged, it's not clear what their needs are, if there's a payer source for their needs, which is the ultimate predictor of whether or not they're going to have services or supports for those needs, and how they're going to be coordinated. We found that many times when someone left the hospital, it was a little bit like the Keystone Cops, that everyone, or the Three Stooges, everyone was trying to get through the door at the same time to help, and then no one could get through the door. So the community care team process, as we built it out and as it matures into kind of organically when it's working really well, does a really good job of helping everyone involved in the care community, whether they're directly involved with the individual or not, prioritize what needs have to come first based on what the client's interested in, based on what the resources that are available look like, and who's available to help. So really, CCTs are just a great type of huddle, right? And it's not complicated. It's, you see, folks have ever been shopping at Target before, right as they open in the morning, they get everybody together and they share a common operating picture for what the day looks like, who's here, who's not here, what's going on, anything exciting, anything concerning. Same with teams. We're sharing a common operational picture for an individual or a partner organization.
Cool. Thanks, Tory. Just to ground in the very basics, right, is what we're trying to do is provide person-centered care and support to really such a wide variety of constellation of needs that folks are presenting with. But especially getting from planning those wraparound services to taking action. That's what CCTs are all about. At any CCT meeting, we don't discuss anybody unless there's a plan of action. Who's going to take the next step or steps? The core belief, right, is that community collaboration is absolutely necessary. Our core understanding that folks what they're presenting with is really complex biopsychosocial challenges, opportunities, and they change frequently from day to day for a lot of folks. So we really need to build a responsive model to address those. And we talk about folks in vulnerable positions having needs, and our efforts to build meeting those needs in the scope of social determinants of health. And it rolls off the tongue just so nicely. And we can read lots of articles, of course, about social determinants of health, and it makes a lot of sense. But operationalizing responses to social determinants of health is a deep, deep challenge. And that's where we really try to dig in terms of community care team effort. Tory, I'll let you take the next couple.
Sure. So this, kind of everyone I think can relate to the concept of teamwork, especially in today's environment. We might be on a number of different teams with folks from different organizations and agencies and maybe even departments within our own organization. Doesn't necessarily mean everybody has the same goal. That's what we found, is that part of the reason for that is that there are some conflicts of interest, both perceived and real, and some competitive interests, both perceived and real, that we've had to navigate. And we will talk a little bit about how the community care team actually helps with that process. One example we had was a challenge getting our local community mental health center involved because they were mad that another community mental health center was stealing their staff. They were training up the staff, they were giving them their first jobs, and then folks were leaving that organization for others. So they were just they were unhappy and weren't feeling friendly about working with that those other organizations that they thought were stealing their human resources. Part of the community care team model allowed us to encourage them to take the perspective of as a training agency and a training organization. So we included them a little bit more in the way we did orientation to the community care team, and they started to really adopt and appreciate their role as kind of guiding and supporting early career workers. And then they saw their role in that pipeline as a little bit different positionally, and that conflict went away. Now nobody has enough staff, so that probably helped too. Want to talk? Yeah, exactly. They should have looked at why their workers were leaving. Part of the reason for the folks leaving in New Hampshire, the community mental health centers, is that their reimbursement rates are just so much lower than private industry behavioral health. It's a whole nother conversation. A quick visit on why community care teams work. Want to show you a couple of different pictures of network maps. And if folks are not familiar with network maps, it's literally a graphic representation of relationships. The first one is a representation of high school student relationships. The second one is a graphical representation of the way people connect on the internet. And this is old, it's probably much denser now. The third one is a representation of relationships at a karate dojo. And the fourth one is a representation of how an infectious disease was transmitted in a cohort in a state that is not in New England. These are all very different looking network maps, but they have a couple things in common. And the thing that I encourage you to take away is that there are connections between the folks on the edges, the folks in the middle. There are nodes that information moves through consistently, and pathways that we can see that look different between high school and the karate dojo and the infectious disease kind of community spread. So we're going to talk about why community care teams work as networks. And it really is because we develop the number of those nodes in any given network. So it looks more like it's kind of a hybrid of all of these, because it really depends on who the players are in the network and what the needs of the majority of the referrals that come to the community care team are. So your takeaway from there is organizations and individuals are nodes. And if you think about your role in that network, what does that say to you about who you're connected to, when you connect, and how you share information? And it is important to talk about how information moves back and forth, how we communicate when we're doing care coordination, because as Kevin mentioned, as I'm sure you all have found, one of the biggest time sucks in your work is doing, kind of trying to track down what really happened here. What happened, what didn't happen, what was supposed to happen, why didn't it happen, with the goal of keeping folks safe at home, reducing risk, reducing harm, and hopefully keeping them out of any sort of expensive healthcare that is that they need on an emergency basis as opposed to a preventative or proactive basis. So that it kind of goes without saying that care coordination is better than care uncoordination. We are better able to value that now, and we do. We'll have some numbers that we can certainly share if folks are interested. But there is both a mathematical reason for improving care coordination and a experiential reason. I have found, I was driving a young man from a shelter overnight to a provider appointment. And I didn't really know this kiddo from anywhere else. And he just said, we were talking about the community care team, and he signed the release, and he said, I don't get it. When people who are trying to help me are trying to share information, it can't happen. It doesn't happen. When the police are trying to get in touch with me, they can share information really quickly. Why can't the people trying to help me share information the same way different police departments can share information? And that question has stuck with me for a long time because he's not wrong, right? It just matters. It matters. So all of the reasons that uncoordinated care just makes our work harder. And eventually, when you have to say, I don't know, or something was supposed to happen and it didn't happen, folks lose their faith that their community supports are actually helping. You know, it takes a lot of energy. It takes a lot of resources for people to do these things. How to get to an appointment, how to get childcare for an appointment, how to figure out if they've applied for all of the benefits that they're entitled to, how to figure out what the timeline is for that, what other proofs they may need. There's a lot of complexity in the way many of our systems interact, and we've created that complexity, but we don't have many ways to help people navigate it. So the community care team really does provide a pretty comprehensive tool for that.
So, and just one more note on this, when I was first introduced to the Middletown community care team, one of the things I noticed was that nobody ever missed the 1 hour meeting weekly, and in fact, people would come in on their vacation for that 1 hour, because that 1 hour was worth 8 hours of dealing with the outcomes of uncoordinated care. And that really becomes cumulative, right? And inefficiencies build on inefficiencies, build on inefficiencies. And it's really the CCT is a matter of turning that boat around and building efficiencies. So I said I would share the evaluation. I mean, it was a really, as a researcher, this was like a pretty quick, straight, very simple evaluation. But the the outcomes of this evaluation were so persuasive that it was used at the state of Connecticut to fund community care teams around the state. Whoever wanted to start one had support from fiscal support from the state of Connecticut. So what we found, again, they had started with primarily folks who were frequent visitors to the emergency room, emergency department, and then it's a natural path of the community care team that the members who come, and we build the membership over time. At the end of every community care team meeting, the question is, okay, who's not here that should be here? And we invite those people and those agencies to be there. And they can sign a confidentiality waiver to come and sit in on one meeting and see if it's something that they think that would be valuable to their work. And it almost always is. And so they end up joining. So then the referral pathways expand, right? So referrals come not just from the hospital, from the FQHC, from the food pantry, from the outreach team, from the shelter, from the cold weather shelter, from wherever. So this particular CCT built quickly. We just evaluated 208 members over a 6-month period, very short period of time. To qualify, they needed 5 ED discharges to get started. Most people had at least 10. Some people had upwards of 80. As one would expect, lots of folks in the 40 to 60 age range, mostly male. Lots of coverage, Medicaid and Medicare coverage in Connecticut at the time. And so we're, again, looking at building a Medicaid reimbursement model very specifically looking at potential cost offsets. We don't call them savings ever, right? But potential cost offsets of Medicaid and Medicare, or at least that those dollars are going to the care that they actually need and will benefit from over the long period of time. And in fact, some of those waiver programs are happening now around the country. Lots of folks with poorly managed behavioral health conditions, which of course only exacerbate over time when you're not getting the help and support that you need. At least 40% folks were houseless, many folks unstably housed. And just in hospital cost avoidance over 6 months, $1.7 million. I mean, and these are 15-year-old dollars, right? These dollars are even much more today. And we were able to demonstrate Medicaid claims reduction alone at 586. So those are pretty darn big numbers for 6 months. Mind you, Middlesex Hospital is not a huge hospital, right? So that was pretty persuasive to lots of folks. Again, this is revisiting kind of the core values and benefits that we were seeing immediately. Especially the one I would highlight, always in CCT evaluations, it's easy to track the benefits to the folks that we're serving in a number of different ways. But the one that I hear repeated over and over is what the participants are learning about each other and their agencies and the pathways, the entryways, the barriers, the requirements that they didn't know or they misunderstood, and coming together with better ways to coordinate among and between each other. That's a massive benefit that can't be accomplished any other way. That building of more and more providers and networks of folks that you haven't participated with and collaborated with before, and folks start to see the big picture, right? I mean, we all live these are all folks that are like yourselves doing really challenging work, on a day-to-day basis, just getting through the day in the context of the services you all provide, is a huge lift. And as Tory said, lots of us are facing staffing stresses now, and many of us will be facing funding stresses in the near future. I'll try not to use any curse words about that, but efficiency is needed more than ever, right? And it's always been amazing to me how you get a much more complete picture of and we use the word client here a lot, participant, neighbor, community member. There's lots of different terminology that we can use. But one of the other things that I've always noticed in CCTs is when it comes to making a difference for the folks that we serve, so often it's something small. Like it's the small thing that nobody noticed, nobody picked up on, that we address that, and that opened the door to all the other big things. Like we see the big things, right? Because they're easy to see, but it's the small things that we didn't pick up on that somebody can bring to the table that we need to know about our friend that we just didn't know before. And if we can address that small thing, uh, great things happen. In meetings, we're always trying to improve the process, right? Back when this was being developed, we needed to get more information out earlier in a more structured way so that everybody could come prepared. Because when we're talking about folks who have really complex conditions, we can spend the whole hour talking about one person very easily, but we can't serve enough people doing that, and it's not necessary. So really working hard to structure the sharing of information, the processing of information, and coming up with next steps. It's an ongoing process, and getting good at that and running cases in 5 to 10 minutes requires everybody to come prepared. And then, just coordinating the overall agenda. Every time somebody signs a release of information and we introduce them to the community care team, they don't go away. It's not a one and off. It's not one and done. That release of information typically is good for a year. It can be renewed. There are members. We own them for at least a year and many more if they continue to renew. Right? And of course, there's equity concerns for allotting time among and between the people we serve and the agencies that are taking their time to sit at the table. And you're always building accountability, and that's another beautiful thing you see happen in community care teams is folks start to hold each other accountable. And that's how you know your community care team is maturing. Tory, did you
I
want
do
to
want to, yeah, I
go
do
ahead?
want to add that for the piece of that give ample notice for the cases that are going to be discussed is really helpful in the early in the building phases because that helps make sure that anybody that might have an interest in that case is sometimes I would reach out and say, hey, we're going to be talking about Kevin on Wednesday. Can you make sure, because some of the concerns are around behavioral health, can you make sure that you're there or that someone from your agency is there? That's really helpful. As that value builds and folks don't need the prompt, we're now at a point where we can take cases in real time, and the folks don't need to submit names. They certainly can, so that we can have the best plan possible to make sure that we run the meeting efficiently. But now, in many cases, it's live. It's folks will check in to see if we have a release. And if we don't have a release, they'll present the case in a de-identified way. And if we do have a release, then they'll present it in that meeting where it wasn't noticed ahead of time. It took a while for that to be something that folks were comfortable with because we found, to Kevin's point about it being a working meeting, that we now have folks from our partner organizations with EMRs who come with their laptops. It's virtual now, but they will be at their laptop able to look up and research clients on whatever database the organization uses. That has made a tremendous difference for them to be able to tell, do we serve this person? What was their last experience here? Do we know anything that is going to specifically inform the questions or the challenges on the table? And we're doing that in real time now without much lead time. So that's one goal. I think that it's kind of exciting.
And that's how you know the team is maturing, right? Is that everybody knows what's necessary to introduce a new case and how to do it, what to expect, how much time is realistic to spend on that case to get where we need to go. And I will say I have a bunch of quotes, right, from this old evaluation. I'm not going to read them all through, except the third one here really tells the story, right? It's a self-reinforcing cycle of camaraderie and positive outcomes. I mean, Tory will share a little bit about, but ultimately this is relational, right? It's not about gizmos, and you need and everybody has to navigate software of this kind or that kind in order to do our work. But I've never seen a magic gizmo that helps make care coordination across agencies and sectors actually work a lot better, right? Usually it's in service of our own agency, and that's totally fine and necessary. But coordinating among and between agencies is person-centered. It's relational. A lot of it's all about relationships, healthy working rapport, decreasing competition. I think it was one of the most helpful things in the New Hampshire case was, we really grew it out with the support and motivated. It already existed when we got the 1115 Medicaid waiver, which is a delivery system reform incentive program. And what that seeks to do ultimately is realign the incentive structure of all the agencies that are working to serve people. And you come to the realization that everybody's doing the work they're incentivized to do, right? And how do you, it's not that we're feeling competitive in our gut. It's that we're incentivized, we're motivated by we're evaluated by our ability to meet these requirements of our funding. So how that often doesn't align well with our partners. How can we realign those um, and still respond to the requirements of our funders?
think Kevin
People start-
introduced this well to our partners in New Hampshire by one of the early challenges we faced was that there were lots of folks from organizations that just didn't know each other sitting around the table. They'd sit with their arms crossed and they would just wait for someone to admit that they didn't know how to do something, or they didn't know what to do, or they weren't sure what the best next step was. It was like the first dance at the middle school, right? Nobody was entirely sure what to do. Nobody was entirely sure who was going to make a fool out of themselves first. And we did have that. That's where the facilitation really is necessary. Spend a lot of time asking stupid questions that I know other people have on the call, but it allows for a more comfortable exchange where I will ask folks not, hey, how come you didn't do X, Y, or Z? It'll be something framed along the, can you tell us a little bit more about how that works or how someone would access that? So it becomes a learning experience for everybody on the call, even if they're not directly working with that individual. That is probably one of the most valuable things that keeps folks coming. We have folks from all sorts of different organizations, agencies, and sectors, some of whom have never presented a client in the entire time that they've been participating, but they learn so much about capacities for what other organizations do and don't do that I think it really is a great vehicle for that.
Mm-hmm. And just a few more quotes here from folks back then, the previous slide, the importance of leadership and just having somebody, like Tory, who understands exactly what's supposed to happen here and helps navigate and bring folks together. Over and over, this is the kind of feedback we get is the importance of the leadership and organization and processing. Also about overcoming obstacles, right? It's rather than just acknowledging, wow, there's an obstacle there. Actually, who can take action? How can we share action? Who's not here that can take action on overcoming those obstacles? And this last piece, the value of including all vulnerable populations that get left out all the time. In particular, among chronically homeless populations, the number of folks with traumatic brain injuries is enormous. And there's not a hell of a lot of tools, right? We don't get a lot of training in how do we support folks with TBI. So learning and supporting each other, right? In in serving folks with a whole constellation of challenges. And we know that creating structures, I mean, there's always a new structure, there's always a new program, there's always a new agency. And we can make, lots of policy manuals and lots of PowerPoint slides that are going to restructure everything until we actually start serving people. It's absolutely not enough. But relationships, have already been deeply ingrained and they take time to change. And that's ultimately what we're all about here. This reflects
Yeah,
also the concept of relational coordination and Tori, I'll let you roll with this because I wasn't super familiar with relational coordination and this group that especially has been advancing it led by Jody Hoffer-Gattel for years. But so I was a little skeptical, but then it started to tick, I think, a little bit for me several years ago. But Tori, you take this one.
Thank you. So how many people have had you've got to make a phone call and you don't know, you've got to connect with someone in an organization and you don't know who the right person is. You know that the organization does that, but your only connection is to call the main number, and heaven help you at that point, because you are having the same experience that the folks we serve are having, right? You don't know who to talk to. You don't know how to explain the problem. A good chunk of the strength of community care teams is the way it builds relational coordination. I wish this wasn't the case, but since it is the case, I'm glad we have this tool that you get to meet people, put names to faces, and get direct guidance from those organizations about who the best person to connect with is, so that you start to build your own personal and a directory. And those connections survive outside the meetings. They become kind of peer-to-peer outreach, and how do I do this? Do you know anything about that? That really strengthens your work on a minute-to-minute basis. I think one of the biggest challenges for the organizations that have not worked in a community care team model is the idea of, I don't even know how to collaborate. I don't know. It's a lovely word. I understand it as a vocab term, but I don't know what it means in practice. Does it mean I do your work? Does it mean I give you my work? Does it mean that we find somebody else to do our work? How do we even identify what work needs to happen, right? So what has changed, I think, as the community care team model evolves, is everyone is moving from everyone sharing what they already do to everyone having a deeper and wider understanding of what other organizations do. So now we've got folks saying, hey, did Kevin get this service from that partner? Have they reached out? Do you know if they're connected? So instead of only knowing what's going on in your agency, you have a better understanding of what the entire field looks like, and you don't have to just wait for someone to say, you're it. You can actually look at the field and say, oh, I'm in. This is my play. This is my role.
That's awesome. So, quick summary, right? The benefits are pretty straightforward. The folks we serve, among the folks who are at the table. The other thing is the CCT really strengthens that there's usually models that already exist in a community or a region or a jurisdiction. The CCT isn't operating in competition with any of those. It strengthens all the existing models, right? If there's a existing care coordination team at the hospital or the 5 hospitals at the FQHC, their participation in the CCT only strengthens their work. If there's a FUSE program, if there's an ACT program, right? Or I know, the CCT that already exists in Maine, right, is opioid health homes, right? Their participation in this particular model is only going to enhance the services and coordination of services they're able to provide to folks. We find that over and over and over. And also, those teams and those models evolve, they change over time, they come and go. Their CCT is also adaptive to emerging opportunities. Actually, we started the CCT in New Hampshire before the Medicaid waiver came. It was really an initiative of the Greater Seacoast Coalition to End Homelessness. I'll share a little bit more about that. But when new programs come down the pike and new funding comes down the pike, and it involves one or more agencies that are already members of the CCT, it's only going to provide more strength to implementing that program. The CCT in Connecticut, well, the one in New Hampshire in particular was also an extraordinary resource when COVID did hit. Yeah, as Tory said, we were going along once every couple of weeks. Um, and when we started the CCT in New Hampshire, we were talking about 30, 40 people in the room together, right? We needed big spaces because we had that many partners coming together face to face for our meetings. COVID hit, no more face to face. Did it weaken the CCT? Absolutely not. Actually, what we ended up doing was meeting virtually 3 times a week by demand among our partners for a while as everybody was trying to get the most up-to-date information. What the hell's going on here? What's open? What's closed? How can I get somebody here? How can I get somebody there? What's no longer available? What are the new resources available? What is the guidance that's available that's accurate? That sharing of real-time information was just an enormous benefit to everybody that was already a member of the CCT. So to start one, you need a champion, you need an organizer, a recruiter. Uh, it's helpful if this is a neutral somebody who's seen as a neutral convener. That doesn't mean, it can't be the person at the hospital. That's how it started in Middletown, right? Um, but it is important that, I've seen people try to start it as a Medicaid agency. It's really hard to do this if you're the payer, right? Um, so it is important to have somebody who's seen as a neutral convener. You invite these service level decision makers, folks that are delivering the services, folks who can make decisions and act on them. We have a whole package of forms. You really want to get those going and get them adapted as quickly as possible. That's easy to do. Whatever the initial recruitment strategy is, it could be the folks coming out of the shelter. It could be folks coming out of the hospital system. It could be, there's any number of different pathways you can start with. They're going to become myriad very quickly. Um, and my greatest recommendation is this is ultimately a initiative where you can plan and plan and plan for weeks and months. You don't do it. Don't do it. It's not necessary. Yes, it takes some time and effort to go through the process of getting agencies added to the release of information. I'll talk a little bit more about that. We could talk about that all afternoon. We're not going to. It's absolutely doable. Key to that is, as Tory said, we are not creating any kind of a new record, right? This is not a new health record, medical record. We are bringing our knowledge and our own records to the table to better align among and between each other. And so with that, we'll show you the list of people who are on the release of information at the Seacoast community care team, which is 65 agencies and organizations, which includes 4 hospitals. And when we started, 3 federally qualified health centers and the local mental health center. So we'll show you that in a minute, all the different sectors. But what I've also experienced over the years is while we want everybody who touches our folks on that release of information, it is unfortunately a barrier and not recommended at all that you include law enforcement. Because why? People don't sign the release. This does not prevent anybody who's serving a population who's engaged with the criminal justice system, right? Whether it's, probation, parole, drug court, whatever it might be, you're still able to serve that person. Absolutely. But when you have law enforcement in the room, so to speak, it really inhibits the kind of information that folks can or will share, whether they understand what's protected or not. And it prevents people from signing the release of information. Otherwise, the ratio of people who are offered the opportunity to sign the release of information and try it out is near 100%.
Yeah, I think in New Hampshire, we had one person request to revoke their release over the 7-year period that we were tracking that for. And we did recently revisit the law enforcement engagement because in New Hampshire, now we have social workers embedded in police departments. That was not the case 7 years ago. We also have social workers being hired into welfare offices or city departments. So this was a tough thing. We had to revisit this conversation. We did have those PD social workers participate, and it was not a successful trial. So happy to talk more about that at a future TA session about how to have that conversation, how to navigate that thinking, and still make sure everybody feels connected and collaborative, even if that one meeting is not the place where that's all visible.
So I'm gonna run a little fast through the next few slides because I want to make sure we have tons of time for questions and answers. We already referenced the origins of the Seacoast CCT. We did start slowly. Actually, I was still working for the Corporation for Supportive Housing when I moved to New Hampshire. There was the Seacoast Coalition to End Homelessness had a big strategic planning thing with tons and tons of partners all at that event. And my inclination was to invite my friends from Connecticut to come up and talk about the community care team as a possible part of the strategic plan. And it was very popular and it was adopted quickly because mostly it doesn't cost money to do it, right? You don't need a new budget. We did secure a few dollars through a United Way to help our friend Maria Solari help to do some of that early coordination, navigation. And I met with all the agencies and organizations that were interested to become part of the release of information. Usually it's about a 20-second conversation. Hell yeah, why wouldn't we do that? Although I can tell you it doesn't always work that way with hospitals. I met with one particular hospital compliance department 9 times. Eventually they came on board. But you know, that's it, is when people start to realize the benefits, more and more agencies and organizations are keen to join. We involved into 3 connected CCTs. There are people that participate in all of them because that's their coverage area, but there are people that are more community specific, right? That would only be in the Exeter area or the Portsmouth area or the Dover area. We'll talk about the package that we can share with everybody. These are all adaptable. There's, you know, it's really kind of a charter that everybody agrees to, and it's a very helpful roadmap for everybody to see that they're all part of the same thing. Some shared principles. There's a confidentiality form for people to sign if they want to join one meeting to see if this is for me. There's then, if they want to join, there's the membership agreement. There's the release of information. We can talk about that, like I said, forever. But it's quite comprehensive. It does certainly address all HIPAA issues, 42 CFR Part 2 issues, and so forth. We do lots of information sharing and reassurance of anybody who may need to understand how to communicate personal health information or not, what they're bringing or not, what they're taking away or not. There's a revocation form, as Tory said, if somebody wants to revoke their permission, they can. They don't have to remain a member of the CCT. It's very, very rare. Also, kind of, you know, simple things like a narrative guide. Like, how do I talk to somebody? How do I invite somebody to be part of this? Well, we just provide a guide. Like, you can, you know, have a conversation that looks like this, only put it in your own words. So resources like that as well. And these are always, you know, open to adaptation. Straight up philosophies of effective teams. You know, we practice harm reduction principles. We're trauma responsive. And that goes for the individuals we serve and, you know, hopefully changing the systems that we operate in to become more adept at applying harm reduction principles and not being part of the problem. Always building resilience, really identifying folks' strengths, building on those strengths, building assets, building their own personal agency, embracing equity, and certainly being keen on the difference between equal for everybody is not equitable. So we're always building equity into opportunities, services, and supports for the folks that we serve. We rethink access, right? There's tons of, I mean, we're in the United States, for goodness sakes. We have so many resources available. Making them accessible is another step that doesn't often happen well in many instances, in many sectors, and making them acceptable, that people actually take them up and access them and use them. We're always trying to look at ways to make our services more acceptable to the people who we serve. And again, practicing accountability among and between staff, right? Not only what do you need from me to help you meet your goal, but for the folks we serve, what can I give you to help support you to meet your goal, right? Everybody has goals here. Getting them aligned is what it's all about. Simple philosophies, right? Principles of transparency, open communication. There's difficult conversations to take place. No doubt about it. This is tough work. Always protecting privacy, confidentiality, using person-centered language, right? We could go through that for a while, but I think y'all can relate to person-centered language, reducing duplication of services, and especially coming to the table willing to change your own organization's policies or practices or procedures, right? Coming to see that actually we can make some internal changes that are going to serve our folks better, and commitment to that realization. And this is the kind of work also, even though the folks at the table are primary direct service providers, the benefits of the CCT flow upwards through organizations really quickly. And we hear hospital CEOs, FQHC CEOs, we hear top level executive officials always bragging about the benefits that the community care team has brought their agency, organization, and their staff.
So one quick anecdote that reflects this. We had a community mental health center and a community in FQHC really not enjoying their working relationship with each other, to the point where they each spoke not nicely about their shared work. And it came up on the community care team that essentially the mental health center had changed their intake policy so that if they got a referral, they waited for the client to call them, as opposed to reaching out to the client, because they felt that that was a better way to protect the individual's privacy and confidentiality. They were not reaching out. The community health center was sending referrals and telling patients the mental health center will reach out when they get the referral. So the FQHC felt like none of our patients are getting into the mental health center. The mental health center was frustrated because they didn't feel like the FQHC was sending people in good faith, because they were never hearing from anyone. And it took a conversation at the community care team for that barrier to be identified. And it isn't that they aren't being sent to you. It isn't that you don't want to see them. It's that you've got conflicting approaches here, and the community mental health center changed their approach to intakes and started to reach out to folks for whom they had referrals from the FQHC. So it made a huge difference. All of a sudden, the pipeline opened up again, and they decided they maybe didn't see each other after all.
Mm-hmm. I think we've covered a lot of the shared responsibilities, collaborative, consensus-driven kind of iterative discussions that take place. So I'll just skip over this slide, but it'll be in the slides when we share the PowerPoint presentation, and this is being recorded, I believe. Again, I can't share all the documents in the package because they're super, super text heavy, some of them, as required. But here's a example of what a case presentation template does look like and can look like for folks coming. And this could be especially helpful for somebody who is introducing a case and just you know, there's so much. We serve people for years and years, and there's so much to share. To be able to boil it down, and you know, we want to honor and be respectful of the person we're introducing. So it's hard not to share the whole thing for about 20 minutes. This can be really helpful in that to get the critical information on the table, knowing that there's always going to be continued convenings of the CCT where we can continue to share that. Also, you know, we have a lot of one-off meetings, right? So, you know, we introduce Kevin, talk about all the things that are going on, what's happened in the last week, you know, what the primary needs are right now, identified who needs to do what, but there's more conversation that needs to happen. So among the 3, 4, 5 people who are at the table who are engaged with Kevin, who up till now all knew him kind of differently, they will have a one-off meeting um, after our CCT meeting and put together that action plan and dive deeper into what they can do with Kevin. So the next time we have a CCT meeting, they're coming back and reporting what further steps were taken on behalf of Kevin. I said I'd share, this is just a list of agencies that signed on to the release of information at the Seacoast in New Hampshire. And mind you, you know, it's not mega, we're not in Boston, we're not in New York, right? I mean, these are 30,000 people communities, Portsmouth, Dover, Rochester. They're not huge cities. Um, so this really represents like everybody who serves vulnerable populations throughout the Seacoast. You can see, you know, the community partners. You see all of the hospitals, all the HQCs and mental health agencies, folks who serve veterans, folks who serve homeless populations, folks who do food, the welfare department. You see also the Medicaid providers who had or have their own care coordinators. And so housing authorities, all right? So, you know, 65 is a big number for that region. And this, you know, fluctuates, people come in and out, agencies come and go, but it's a pretty darn robust multi-sector representation of not only the folks we serve, but it represents a lot of new referral pathways where we're bringing in folks that we didn't know because they haven't been to the hospital in 10 years. They haven't been to a health center in 10 years, whatever it might be. Um, so important processing, plenty of notice if you can. Although, as Tory said, you know, once you become a mature CCT, folks learn how to introduce cases in real time. But coming prepared really is important. And then that follow-up and accountability, shared care planning, and one-off meetings in between. The coordinator has a number of responsibilities. You know, maintaining secure and non-secure email distribution is a big one. You can do secure Dropbox or cloud-based file system, keeping all the program documents updated. Getting material to folks in advance and being responsive to new demands, right? Super efficient in facilitation. That's a skill Tory has. That's really hard to develop over time when everybody's so complex and everybody is trying to do a lot of good, and then coordinating those one-off meetings. Tory, I'll let you go through the 3 CCTs in New Hampshire here.
Sure, and I'll be really quick here because you can read the numbers, very similar to the evaluation experience that Kevin had with the Connecticut team. We just continue to talk about a lot of folks with really complex stuff going on. And they often, we have evolved so that there is not a standard of eligibility. That was something that I think a lot of teams in New Hampshire, when they were trying to get up and running, really struggled with, that folks were being screened out when the advising or the organization that had concerns, I think really is the best organization to identify whether or not they're struggling. So usually the case is complex for a number of reasons. Sometimes it's clinically complex, sometimes it's socially complex, sometimes it's, there just isn't a lot of information. Most of the time, if it's complex to an organization, that means they don't have the knowledge, skills, or resources to meet that individual's needs. We never, ever want to say, oh, that individual isn't complex enough for this team. So I think that is probably the most important takeaway, is that these numbers can look however they look, but the best measure of eligibility should be, is someone who is connected to them struggling to help them.
That's great. For sure.
Yeah, we can just keep on moving. This one.
That's great. So I think we succeeded in leaving a solid 15 minutes for Q&A. So I'm proud of that. So we do, again, for anybody that's looking to implement from scratch or adapt or an existing effort, we have these next 6 Wednesdays at 1:30, hour-long time set aside. Or if, your agency or organization wanted to request some just one-off time with us, and for example, this hour doesn't work on your schedule or whatever it might be, we're happy to do that too. There's a link for going through and making that request at CCSME. And otherwise, I'm going to keep my mouth shut, open the floor for questions. And I think
we did have a question in the chat. I'll kick off with, and then folks, it's up to you, Bethany, how you'd like to move from there. Do you want me to address the chat questions, or do you have some you'd like to start with?
Yeah, if we can answer, before we begin questions, I want to point everybody to the link to the community care team technical assistance and coaching time. If you would like to sign up for one or all of those sessions, the link is also in the chat, and I will be shortly putting the survey link in the chat. But yes, if Tory, if you wanted to answer Brandon's question first.
Thank you. So there's a question in the chat asking if we can share examples of how community care teams have prioritized cases when there are too many to cover in any one meeting. It's a great question because it does happen, and you never know when one is going to turn into a 20-minute chat or a 7-minute chat. There are 2 main strategies that we use here. The first is asking folks to identify people that they want to touch base about at the beginning of the meeting. I usually ask folks to put their own name and organization in the chat because that helps us familiarize ourselves with who's there, and a name and date of birth of anybody that they want to check in about. That gives me a sense right off the bat if we have a handful, if we have 2, if we have 17. The other thing that I'll do if it looks like we're getting close to time is use the time that we do have to craft the micro team meeting where, hey, it sounds like there are 3 folks that are probably the most critical people who need to connect around Kevin's case. Let's share that with everyone and see if anybody else is working with Kevin, and then set up a micro team and identify a lead person who is willing to coordinate those folks. So if time is tight, we really prioritize identifying anybody else on the call that is working with that individual and identifying one person to be the lead, just to reach out and try to schedule a micro team with those folks that were either identified or self-identified as working with that person.
Thanks, Tory.
Any other questions you can place in the chat, or you can raise your hand and unmute, either physically or virtually. Yeah, and I also placed the link that Kevin had shared in the slides for specialized technical assistance. So yeah, if that time from 1:30 to 2:30 does not work for your organization, you can always request specific technical assistance from the MESUD learning community.
I'll ask one more question. You mentioned you mentioned Fuse as like a another type of initiative or group that might exist in the community, and just wonder if you could talk a little bit more about that, and how just in the sense that I don't really know like what a Fuse team looks like, or could look like, and so maybe just help differentiate that a little bit would be helpful.
Sure. So, I mean, few teams can take on kind of different characteristics depend on where they are and what their priority population is. The history of Fuse was that it was serving folks who were coming into very consistent contact with criminal justice system. And many arrests, lots of overnight stays, lots of time in court, and how could we better serve that population? Since then, the concept of Fuse has been replicated around the country, serving all kinds of vulnerable populations, not necessarily only those criminally justice involved. So it a little bit depends on the characteristics of the Fuse program in any given jurisdiction. But even if it is criminal justice involved, right? Often in a Fuse team model, you certainly do have folks who are working on behalf of the criminal justice system, and that's fine, that's important. But typically, we also build those teams out to have other agencies involved who are providing social services to the same population. Those are the folks who would attend the community care team, and not necessarily to reconcile any particular legal issues, right? Because that's part of what we do in Fuse is help folks to reconcile legal issues that they don't have the resources to deal with, or any number of reasons that things aren't working out for them in criminal justice world. But there's also all those underlying factors and related factors that folks who are from other partnering agencies are trying to address in consort with partners in criminal justice. So those are the folks that would come to the CCT, and could introduce and discuss the folks they're serving on the basis of those needs. And again, that's a conversation one would have in the informed consent process, whereby, hey, I'm working with you, Kevin. I work for this agency. I met you through the Fuse program, and we're trying to reconcile and clean up some of this legal stuff that you're dealing with, so it has the least possible negative impact on your life. And I've been working with you on all this other crap that's going on. And if you're interested and willing, I could bring your case to this group of folks that I work with, who are all, super focused on being helpful. I won't share any of your legal information among and between folks, but rather just all of the other constellation of things we're working on together. And folks usually agree to that.
That's great. Thank you.
Sure.
I did just pop into the chat the schedule for the New Hampshire community care teams with an invitation to anyone who would like to sit in on one and kind of see how they work in their kind of mature status. You can feel free to reach out to me, and I can share with you what you need to sign and get you the access information for that.
Thank you so
And I
much,
would say,
Tory.
yeah, the Stratford County meeting is usually the largest and the busiest. The others are busy. The Stratford County is consistently busy because we have 2 hospitals in that catchment area, and the other 2 teams each have 1 hospital. And just by nature of volume, that has an impact on how many cases we see.
And I'll be sure to include this information in the follow-up email as well, just in case anybody wants to contact you later and join one of these meetings. Any other questions? Either can be placed in chat or put unmute and ask. I'll also use this opportunity to share that tomorrow Kevin will be coming and sharing a quick 30-minute talk about the harm reduction resources that the MESUD along with RHI are going to be providing in the month of April. So if you'd be interested in joining us for that, we'd be very excited to have you. And Kevin is also providing a presentation on HIV later in April, and we have lots of and an in-person train the trainer in April as well. So keep an eye on our calendar because we have a lot going on. Any other questions?
Bethany, I'd be interested in hearing from folks if they are have any thoughts to share about the biggest challenges in coordination for the work that they're doing right now, in connecting and coordinating. Because a community care team is a great tool. It may not always be the best next step, but I'm always appreciate the chance to learn from people about what the hardest things to learn are. Like, for example, in New Hampshire, we tried a shared care management platform based on the work that the community care teams did, not to create a record, but to facilitate communication between different organizations. Did not work, didn't fly. The state is now trying to roll out a closed loop referral system that called Unita, the Find Help, the Find Help platform. So we're navigating kind of how will that tool help community care teams do their work? Is community care teams work being included in consideration of the way this tool is built? So there are some kind of bigger system conversations happening around community care teams at this point. They're really valuable for small. I guess I just want to say that it's scalable. It can work in a community of 100. It can work in a state of 1.3 million.
Mm-hmm.
Sherry said, oh yeah.
ROIs are a huge obstacle. So releases of information to communicate with other providers. And so that's absolutely something that we can speak to. I know Kevin did the heavy lifting to get some pretty tough compliance spaces. And remember that this started when Part 2, 42 CFR was newer. So we had to navigate that uncertainty as well. And for the most part, we've managed it in the way we communicate around what we communicate around. So and we have those resources to share as well.
Brandon
I love
says,
that.
I'm not immediately aware of what the biggest coordinating challenges are. I do know that there are some coordination inspired groups that already exist. Some have ROIs, some do not. Some include law enforcement. This is in the Portland area. Others from around the state here can speak to challenges better than he could.
I think that's the best phrase I have heard in a really long time, coordination inspired. That is such a great phrase, right? Because I think that most of these groups are absolutely coordination inspired. What is the outcome of that inspiration? Is there actually better coordinated experience? Most of the time on the community care team meetings that we hold, the things that it's not the client that needs to do something different, it's the providers that need to either stop doing something or start doing something differently or connect with somebody or a different organization in a more effective way. That's a great phrase. I don't, the law enforcement, I think it's not always appropriate to have them in these settings. It's not always inappropriate to have them. And it is a case by case consideration, I think. And there's nothing that stops someone from having what we'll do usually is if there's a need to, if someone has is justice involved, like they're participating with community with our community corrections program. We have a big population that is not incarcerated. They are, they have community monitoring. Those folks are not included on the community care team calls. They will often have a conversation with the individual and say, so, that we talked about your case at community care team. Here are some of the thoughts that came out of that. One of the recommendations is that your corrections case manager is a really good contact for that. Is that someone that you want me to connect with, that you want me to support you to connect with? So those relationships still happen. And if the individual gives permission, for the corrections case management person to talk to someone, then absolutely they will. So the release really only manages the community care team discussion. And in my experience, law enforcement doesn't concern themselves too much with whether or not they have consent to share information. So that's another reason why the community care team meeting itself may not be the best place for them to participate. But Kevin has facilitated other conversations, the diversion programs especially, where they are at the center of the conversation.
Mm-hmm. We've also the benefit of having made many, many mistakes over the years. So happy to help you learn from those as well. We just don't put those in the PowerPoint slides.
Right.
Thank you so much, Kevin and Tory. They've also shared their emails, which I'll be including in the follow-up email. So if there is a question that you weren't able to get to, or if you wake up in the middle of the night thinking of something, you can either send me a message or send Kevin or Tory, and we would love to hear from you. But thank you so much for joining us today. Thank you, Kevin and Dr. Jennison, for this wonderful presentation, and we hope to see you all again soon.
Thanks, y'all.
Thank
you.
Have a great rest.